So our last speaker today, we're going to bring it back to maternal, newborn, and child health, bring it back to saving lives at birth. And our last speaker is a highly empathetic, systematic, gritty guy, Alain Labrique, who is an epidemiologist, a sort of innovator in his own way, and he's both in terms of community engagement as well as he never fails to impress me with what kinds of tricks that he pulls out of his bag. So hopefully he can share some of those stories with you. So Alain currently is a director of the M-Health, Johns Hopkins M-Health, Global M-Health Initiative, as well as an assistant professor there, and certainly is on my list of future stars in this whole area. And I'll leave it to him to, he doesn't have small shoes to fill, but he's a very powerful speaker, and I know will lead us and inspire us to the reception. So, Alain?
Great.
Good, you got it.
So I'm going to start with showing you the technology that I was wowing Charlie and colleagues over the lunch break. But basically it's, some of these innovations that we have in our pockets enable us to hearken back to folks like Pliny the Elder, who said, in vino veritas, and I think I'm the object that stands between us and the truth and serum that comes after this talk. So it's really a privilege to be invited here and share some of our experiences in global health, but also the chance to see many old friends, some of whom I haven't seen in years, some of whom I just saw in Baltimore a few days ago. So, we share a common struggle, those of us who are gathered here today. It's really a drive to make a lasting impact on the human condition. But in the past 50 years, we've really seen the globe undergo transformative change. We're connected today in more ways than we've ever been connected before. Many of us have set foot on nearly every continent, often many times in a single week. I just had dinner in Kathmandu 2 nights ago. Last night I was sharing a drink with you guys at the tower. And today I'm in Seattle, and 2 days from now I'll be having dal and rice in rural Bangladesh. So, it's a really convoluted space we live in global health, but I'm glad to be sharing a lot of empathy with all of you here today. So I've been given 20 minutes to share some of our experiences from Bangladesh with you. And as an epidemiologist, we look at the world statistically in many ways. So let's do that in 20 minutes. And one of the things that all of us know in this room is that in these 20 minutes, 28 women will have died from preventable causes, either during or as a result of childbirth somewhere in the world. Now in Bangladesh, the country where I was born and raised, the volume of pregnancy-related deaths is the rough equivalent of one Boeing 747 filled with pregnant women and new moms, crashing every 2 weeks. Now, in India, this is about the same magnitude, yet this tragedy does not make global headlines in the same way that we see global economic crises or some scandal in Washington making the news. In these 20 minutes, 230 children under the age of 5 will die, primarily in the first 4 weeks of life. The majority in the first 2 days after their birth, primarily because we could not get simple, proven solutions to them in time. So today what I'd like to do is take you on a journey, traveling back across the ocean, this time without the jet lag, to a country where many of the public health giants have cut their teeth, and where many global health innovations have originated. In Bangladesh for over a decade, with colleagues at the Johns Hopkins Bloomberg School and with local institutions in that country, we've set up one of our flagship maternal and child health nutrition research sites in South Asia. So a harrowing 8 to 15-hour journey from the capital of Dhaka, dodging buses, cows, people, randomly crossing the road, gets us to the heart of rural northwestern Bangladesh. And here is where we find the Jivita Population Research Site. Jivita, the Bangla word for alive, is also a play on vitamin A, which is where a lot of our initial work was focused. Dozens of large population-based research studies in this site have been supported by the Gates Foundation, USAID, but really with strong engagement from the beginning by the government of Bangladesh. We cover a size of over 4 times that of Washington, D.C., and we set up this site in 2001 to test simple, low-cost solutions aimed at reducing maternal and neonatal mortality. So the research population is a typical cross-section of rural Gangetic South Asia. The goal, set up under this foundation's Grant 614 for the global control of micronutrient deficiency, was to develop local capacity to do the rigorous research necessary to generate evidence from a population that's resonant with the greater Gangetic floodplain to support the innovations today that make up tomorrow's programs. And so nutritional and infectious disease research from Javita have helped to shape both national and regional policies for South Asia, as well as, most importantly, train young scientists who will bear the mantle for developing those programs in the future. So over the past 12 years, over 850 staff, 95% of whom are local women, employed for the first time, have enrolled 130,000 pregnancies, reflecting a weekly enrollment of about 300 pregnancies identified every week in this site. Roughly 265 babies are born every 7 days within our research catchment area. Now, in this population, over 85% of the babies are born at home. 45 out of every 1,000 neonates do not survive that first month of life. And roughly half of those newborns weigh less than 2.5 kilograms, classifying them as low birth weight. Now, we know this with certainty, as half of our babies are reached within 6 hours of birth for initial assessment, and then we weigh and measure them with digital scales within 18 hours of life. So these aren't guesstimates or population surveys, these are actual head counts of what's happening on the ground. Our frontline health workers are present where and when they can collect information that helps improve our understanding of these complex trajectories to mortality that result in the tragic outcomes that we're gathered to prevent today. Over the past decade, we've GIS mapped the entire area as part of the infrastructure to conduct large randomized controlled trials. Over 250,000 points collected by GPS, allowing us to explore the spatial dimensions of 105,000 pregnancies as they've occurred over the past 10 years. Here as purple dots, 80,000 births as they've occurred, shown in blue, and where over 1,000 neonatal deaths, shown in red, and where 1,500 mothers, shown in yellow, have died. To look for new and innovative ways in which we might be able to act to reduce the mortality in this and similar populations. So the responsibility of being entrusted with this kind of data is tremendous. Thousands of maternal and infant deaths captured in excruciating detail. But this is not just data. As you just pointed out, these are the personal trajectories of so many families that we have to learn to share and apply to be able to divert the trajectories towards survival. But we also have the privilege through this data to see the big picture, to see patterns and the repeated obstacles that remain hidden and unseen when you're on the ground, seeing only one event at a time. So let's travel a little further into Gaibandha and take a look at some of the things we've learned. We go to a small cluster of homes, mostly thatch and mud, a few with tin roofs. Nearly 2/3 of this population has no electricity, but 70% of the households, as of a survey we did 2 weeks ago, of 130,000 women of reproductive age, showed that they had household cell phones. Women who owned these cell phones were 3 times more likely to have made a call related to an emergency health situation in the past 3 months. Across this wide swath of rural South Asia, again, most of these women are giving birth in the home, but rates of skilled birth attendance has gone up ever so slightly in the past decade, a little over 10% in this population. Most women rely on traditional dyes or birth attendants to help them through the delivery. Now, even when faced with a crisis in pregnancy, most families seek help first from non-certified local traditional healers and untrained village doctors, narrowing the chances of survival when they do finally seek care. So here we have to consider what are the underlying motivations for making such a decision, some of which involve cost, transportation, distance from care, but also traditional belief systems, and perhaps prior bad experiences with broken health systems. So let me read to you from one verbal autopsy where we hear about this disconnectedness. The woman lived alone with her children in an isolated part of the community, far from any other homes and health posts. Her husband was a migrant worker in another district who was not able to provide enough money. She often went hungry. In delivering her third child, she became very weak after delivery. She had sharp pains in her stomach for which a village doctor was called, but could not treat the condition. Her neighbors contributed money for her to go to an MBBS, a certified doctor, but she died in the clinic the next day. Often in these situations, it's the inability of the frontline health worker, in many cases an untrained traditional birth attendant, to manage a complex situation such as this one. A 20-year-old woman, Anjuara Begum, who experienced obstructed labor, explains, "When I tried to give birth, the umbilical cord came out first. The dai who was helping me called 2 other dais. They were afraid to touch me because they said they had never seen anything like this before. 2 hours later, my family called an ambulance, but the baby was already dead, probably from the cord being wrapped around its neck for a long time." The fact that most community-based providers have been isolated, working not only outside of the formal health system, but also disconnected from the health system, has made it difficult to use their proximity to the crisis events to be part of a process that can save the newborn or maternal life. In this 450 square kilometer area, there are no facilities offering obstetric surgery. The clinics and hospitals that are functional and can provide emergency obstetric or neonatal care are located in the north to the town of Rangpur, at least a 2-hour journey by vehicle, or a 1-hour journey south to Gaibandha, the other major city. Complications that occur in Gaibandha have to travel, again, 2 hours to the west and then north before they reach facilities. So this leaves a population of 2.3 million with having to travel for hours at a time to reach facilities, often on local transportation. Here's a vangari, a common mode of transport in this area, on which the entire family is accompanying the pregnant woman to the hospital or clinic. Can you imagine a new mother suffering from postpartum hemorrhage, being taken down a dirt road, being jarred by every pothole, or a swaddled preterm neonate being rushed to a facility? This is why it's so important for our innovations to take into account context. We need to focus for now on where and when families go into crises, while we build the infrastructure for future health systems. Local belief systems and fatalism may contribute to delays of seeking appropriate care. Of course, every belief system values the life of a newborn and the mother, but we have to understand the traditional belief systems. In this setting, like many in South Asia, infants are protected from evil by making the newborn seem imperfect and thus less attractive to spirits, here with a black kajal circle on the forehead. We GIS mapped homes where evil spirits were reported by parents to have played a role in their infant's death. Now, a total of 14 different kinds of evil spirits were named in this large population. Of course, these were more often for ambiguous causes of death, such as birth asphyxia or sepsis. But what's not clear is whether this belief system contributed to the delays in seeking medical care first. We often see maternal and infant mortality reduced to a single cause of death, while recognizing that when a mother or infant dies, it's a result of a complex series of compounded conditions, decisions, barriers, and system failures that all combine into a perfect storm of malfunction. This is data taken from Manjuara Begum's verbal autopsy. After she developed a high fever a few days after delivery, her mother-in-law pressured the family to stay home. They called a homeopath, who then suggested they call the untrained village doctor, who decided to transport her to the local community clinic, but no van was available. So they said, let's call the NGO doctor to the home, but by that point, it was too late to act, and she died. In another illustration of compounded delays and decisions, we see how Alea Begum's family decided to wait for a day when she first experienced a convulsion in late pregnancy. And the family sought care from a faith healer, and only when that didn't have results, they went to a facility, but were unable to afford care, so they went back to an untrained village doctor, soon after which she died. We see over and over these trajectories in mothers and newborns. Here's a story told by Amina Begum. In addition, so at the beginning of my pregnancy, I bought an amulet from an herbalist. When my labor pains began at 8 months, my family called a village doctor, who injected me with saline and medicine. I delivered a boy who was neither breathing nor crying. The doctor shook the child and blew in his mouth. The baby began breathing but didn't cry. The doctor said that my baby had pneumonia, since there was a grunting sound in his throat. He gave medicine and said it was doubtful the child would survive. He advised my family to take the child to the hospital, but we called a homeopath who gave some pills and said the child would survive if he was destined to live. And my boy died later that night. So in addition to innovations that help us improve the quality of care, both during and before crisis events, we need to think about innovations that transform the underlying context within which these deaths occur. Can we mobilize communities with improved access to information and data about the health of their mothers to develop social movements around preventing maternal and neonatal mortality? Can we, understanding the value of traditional belief systems, help families take appropriate decisions sooner? Health systems include not only the hospitals and the providers, but also the family members and the community leaders who influence decisions to seek care, both before and during delivery. We need innovations that get young doctors fighting over who gets the privilege to serve in a rural community. We need innovations that help communities work together to ensure successful pregnancies instead of shrouding mothers-to-be in shame. And we need innovation in getting simple strategies which we know can save lives to where they are needed within the window of time when they can have the greatest impact. So what we have learned from women and newborns who die in childbirth and early life is that we need a sea change in integrated end-to-end systems. We need to continue to generate new evidence-based vertical innovations that save lives, as we and many of you in this room and our colleagues have shown with newborn vitamin A, under 5 supplementation with micronutrients, chlorhexidine cord care. But we need innovations that fit into and strengthen the way care is delivered, but also how it's expected by the populations which we serve. Now, one way to do this is to work with the critical stakeholders from the beginning of the process. So there's a pathway to ownership and adoption down the road at the end of the integration. One example is the mobile phone revolution that we've all witnessed over the past decade, which has in many remote rural parts of the world connected women, families, and frontline health workers in new and exciting ways. At my last count, nearly half of the finalists for these grants address E or M health in their proposal. So at Johns Hopkins last year, we launched the Global M Health Initiative, linking over 73 projects across the university, doing rigorous research and innovating solutions that use mobile technologies. But we're also excited to be part of a global M-Health community, scientists and innovators, many of whom are actually here at this meeting, working with the frontline health workers and health systems to identify the optimal ways in which these technologies can be used to connect frontline health workers into the mainstream health system, to compress the time between the crisis and care. Over the past 2 years, we've actually pioneered a mobile phone labor notification system, which at first we were very dubious could actually work. We were able to get skilled emergency obstetric care nurses to the home to help conduct a safe, clean delivery 90% of the time in this remote rural population of Bangladesh. Finally, we're using mobile systems to enumerate and count pregnancies and births across this swath of South Asia, developing frontline health worker surveillance and scheduling systems that can be ported into the formal health sector. So governments and communities will soon not have the excuse of saying we don't know how many pregnancies or how many births or how many stillbirths or neonatal deaths we have, having to rely on guesstimates. By counting women, we also enable accountability of workers and of the health system that we're working within. So in the developed world, we expect pregnancy and childbirth to be part of a continuum of care that continues not through childbirth, but also into adolescence. We now have the technical capability to provide the same continuity of care of women and children in rural populations, as opposed to this discontinuous, sporadic contacts that they've learned to expect. Now, the challenge for many of the innovations that we've seen in global health is that they sort of languish in that trough of disillusionment that we see with the Gartner hype cycle after their initial demonstration. They never go to scale because they lack integration into the health delivery systems, or they lack sustainability or evidence, but even sometimes, tragically, because they're just ideas ahead of their time. Now, each of the innovations here attempts to address or remove some of those obstacles and to push upwards those trajectories of mortality that I shared with you a minute ago. We increasingly have the technical capability to make sure that every woman, family, and child is counted, and to make sure that every newborn has the maximum chance of survival and healthy life. So even 10 years, if we haven't used these innovations that connect individuals, that compress time, that create opportunities for intervention to save lives and to take us that last mile, it won't have been because we were technologically incapable of doing so. So I'll leave you with saying that the bottom billion of this world are connected. And it may not be long before we see an Arab Spring of informed and empowered families demanding better health and nutrition services. We focused for a long time on how to get innovations that overcome getting care to people. But now we really need innovations that get people to care. Thank you very much.